So we now have time for comments from the participants. So if you will go to the microphones, and if you don't have thoughts, we can let our panelists opine about the things they didn't get to say, or maybe in reaction to what they heard from others. But I see at least Mariah going to the microphone. So let's start with Mariah.
Yeah. Okay, so I'm Mariah Merritt, Johns Hopkins Berman Institute of Bioethics and Bloomberg School of Public Health. So it struck me that both with respect to the debate that happened this morning regarding whether or not it's okay to just accept free services from a digital platform with the knowledge that they're using your data for their own purposes, and with respect to the point that Tanya made just now about patients bearing more and more of a burden that really may not be theirs to bear, it struck me that there's sort of a collective action problem among citizens and patients. It's like if we all decided to not do that, then no one would have to do it, but we don't get together and decide. There's not an organized way in which we can protect our own interests or even articulate them collectively. And it, just with respect to the technological questions from the first two sessions this morning, I don't want to forget that Europe exists too and has a very different regulatory regime from ours. And so there was a sort of fatalistic attitude, I thought, about, not being able to regulate this stuff in any existing way, but I'm just curious about that. I don't know whether it's relevant enough to the whole trajectory of our workshop today to spend a lot of time on that comparison, but I just wanted to point it out.
I'm happy to respond to that because I think that this, at least from my point of view, this might be one of the key action areas to think about for just direction of intellectual inquiry that'll make a real difference, but also prodding of your funders to see more funding to support this. Which is, I guess my view about it is that there's enough evidence on the table now with the way that big data is being handled, the way that corporate interests have a certain kind of autonomy. Even very interesting issues that were brought up about the relationship differences between citizen science and self-science. That from my point of view anyway, I actually think that the question about whether or not you can just reform your way around or regulate around and keep maintained a patient-centric orientation to research as we've done our best to do. I think that era is gone, in my opinion. I think we actually need to fundamentally reorient ourselves to a completely changed world. And I know that there's often a lot of concern about the sort of runaway train effects of some of this, data being moved around, and those are known issues. Kaiser buying all of Myriad data and things like that. So people were well aware of this, but there are actually other jurisdictions in which fortress mentality around health data actually stifles innovation. I certainly live in a jurisdiction where the previous privacy commissioner twice scolded the Ministry of Health publicly, which is a very unusual thing for them to do, because she said that the middle managers in the Ministry of Health were so risk averse that they were actually keeping useful data out of the hands of the innovators and in the process essentially crushing possible R&D partnerships that would actually help the population. So there are issues like that, but then there's other big things to work on too, which is I think that one of the things we didn't really hear much about throughout the course of the day is the fact that with all of these changes in the way that data is driving these different kinds of collaborations and identities within the R&D system, some of the customary, institutionally enforced ontologies about expertise are also going to go out the window. And I think that that's one of the really interesting questions. And I think it's a fundamental small be bioethics questions to figure out who has expertise and standing in a very, very changed landscape of practice around this kind of work.
Anyone else want to speak to this? Okay.
Well, I just want to clarify what I meant when I said the increasing burden on patient communities. So I think there's lots of different contexts and ways in which patients, especially patients with very complex care, are trying to want access to their data, and you have a right to your health record under HIPAA, right? And so, but it's not that easy to actually get it. And sometimes they want it for continuity of care. They want to share it with another provider. They want to get a second opinion, whatever reason it is. There's also kind of, I think, sort of a movement of patient communities, and we just funded 30 rare disease groups a couple of weeks ago to help them to create collaborative research networks and to try, and in rare disease, there's a feeling that these diseases are very neglected, that there's not a lot of incentive in the traditional academic research model to study these diseases, and it's obvious why. It's like if you're a young investigator, you're not going to spend 2 years trying to find the 50 patients around the world with X, ultra rare disease, and then figuring out how to collect their data. I mean, it's going to take you like 2 years to do that, right? Maybe, or maybe more. So patients are realizing they need to do this themselves. They need to build the research enabling infrastructure to attract researchers to their disease and to actually accelerate research in their disease area. That's a huge burden to take on, especially right now. There's not infrastructure to really support that model, right? There's not a lot of, how do they do that? How do they be good stewards of their data? How do they think about how to, first they have to organize their community, then they have to develop trust with the patient community, they have to collect their data, they have to build a registry, like all these things, right? So that's what I'm saying. I think it's enormously challenging, but I think they feel like that is, but it's also incredibly inspiring to see these groups actually organizing themselves. It is a form of organizing, right? And I believe that maybe this is the way to start changing the ultimate paradigm, because when you have patients doing this over and over again, you're really building a broader patient movement about accelerating research on the terms of patients. I think it will lead to the kinds of changes that I think we want to see, and these bioethical issues will become front and center, I think, for these communities.
Great. Liza.
Hi, is this on? Yeah. I'm Liza Dawson. I work at Walter Reed Army Institute of Research, but I used to be at NIH for a long time. So I want to, actually, I'm shifting the topic a little bit back to what Dan was talking about in his remarks, which I deeply appreciate, about the need to broaden what bioethics is, and also about the need to have a strategy about bioethics. And I think one of the struggles that I had while I was at NIH trying to support bioethics from the perspective of being in the funding organization and not having a lot of leverage was that there was a constant press and push from the leadership of various scientific programs to keep everything about the science. And so all the bioethics, if there was any, had to be linked tightly and subservient to, it's all about how we can do our research better. And, if there's a slew of R01 grants going out, it's really hard to parse out one more R01 for bioethics if it means one less scientist is going to get funded. And that reality tends to be very tough for making programmatic decisions to support bioethics work in a more comprehensive way. And so I think what's needed is just what Dan said, which is to really have a much broader look and a better strategy, which is we don't need bioethics work or history of science or anthropology or sociology, which I agree are all part of the many disciplines that we need. We don't need them to make research better. We need them to make society better. And to make society better, we're trying to use our tools, all the tools that we have, to improve people's lives. And that includes the structural as well as the biomedical. And it includes that in the mandate of using all the tools we have to improve health or to improve justice, that interdisciplinary approaches like bioethics are among the tools we're going to need. And so they shouldn't need to be justified by, they are an adjunct to doing a good research protocol because we have to get informed consent. That's not the justification. The justification is we can't possibly move progress in these areas without a broader look, and we can't do it unless we have the interdisciplinary work that all of you are doing already. So I think that's the kind of strategy we need, and we just need more people to embrace it.
Can I just say a little bit about that in terms of programs? Because I completely agree with you, and some of the work that I'm doing with Genome Canada right now is to say that, you know, they're an organization, you know, that's for society that does genomics, if you will. I know that's kind of clumsy language, but I think you get the intent behind it, which is that the fundamental social mission of doing the science and you know, scientific research and technology development is the improvement of lives, increases in prosperity and wealth. I mean, just kind of obvious social wins. So then the question is, how do you actually make all of that sufficiently mission driven that you reflect that overarching value proposition and programs that actually, you know, deliver on that. But along the way, part of that, what that means is we used to call it just, you know, sort of bolt-on bioethics as the last thing that we wanted. That it wasn't interdisciplinary or integrated. If you took just add a bioethicist and stir, and you get an interdisciplinary. It doesn't work that. It obviously just doesn't work that way. So like some of the work we're doing right now is to build into review criteria, and to write guidances and give examples to show what meaningful natural and social scientific integration and interactions really look like, and what they can actually produce. The limit case in this, I think, is where you get, instead of, you know, the kind of repression of the social sciences and humanities to the barest minimum, is you get the inverse of that. You get the other type of project where we've had some of these, at least one of them that I know of reasonably well, where it was actually structured as, and this was one of these large-scale applied research projects, it was actually structured as a social science project where the central question was around using genomics tools to enable remediation in forestry. But the entire way that this was done was it was working with Indigenous communities. So it actually started with a consultation process that was led by Indigenous communities to set the highest priorities from their perspective about what was happening on their lands, and then that structured the science. And you know, once you've done that, you've actually built in an integrated project that also, I think, has a very clear return, a very clear deliverable back to the affected communities who actually wanted to see the science done in their name. But you know, it's only made possible because we actually have a funding program that permits that kind of thing to happen. And in some funding systems, that might be viewed as a perversion of the natural course of things that science leads. That, you know, if we do this, that birds will start flying upside down and things like that. But in fact, you can actually generate fantastically good science and technology development by letting the social sciences and humanities lead with the problem structuring.
Please.
Building on what Liza just said really compellingly there about it's about making the world better. And I think one of the strategies we have employed within humanities and social science at Wellcome is to think about what the humanities and social sciences and all the disciplines that make up this broad field of bioethics, what are we good at, okay? What can we bring to the table? We fund a lot, for example, we fund a lot of literary studies, a lot of English literature. And I say to my science colleagues, you know, Shakespeare isn't going to cure cancer, right? We know that. That's a silly claim. But the study of literature can help us really get, and this comes, I think, to your point, really help us understand the way in which people, and the communities precisely the people you're talking about, experience those illnesses and those particular disease conditions. There are skills and expertise in the humanities about getting at lived experience. There are skills and experience and expertise in the social sciences about structuring that lived experience and forming the questions that science just doesn't do, right? It's not part of their wheelhouse. And so it's really sort of incumbent on humanities and social science and the disciplines within bioethics to start talking really loudly and confidently about what we're good at and what we can bring to the table, rather than saying we can do, well, this is a replacement for science, or this is a critique of the science. Saying, no, actually, we are part of the solutions to the problems you've got. And that begins to be part of a more compelling vision.
I see, Eric, but I want to insert myself quickly here, which is a little bit in response to Liza and what both of you just said. It feels to me like among the things we haven't talked about at all and that we could and are good at is being available when things start to go badly and helping to address ethical issues as they arise. So obviously the issue of the moment is coronavirus. And maybe, Dan, I'm gonna call on you here. Talk about sort of rapid response opportunities, because it feels like those are the kinds of things we can do, but it's a ponderous process by which we have to go through investigator-initiated research proposals to be helpful. And I know, Liza, you reminded me of this issue because you used to work at NIAID. So it feels like that's an opportunity for us to try to figure out. And I know Wellcome has created a mechanism by which you can do something like that. So maybe you can say something about it as a way of planting a seed for further discussion.
The rapid or the availability of the bioethicist on the phone 24/7, ready to help with the moral problems of the day. On call. Yeah, precisely, right. It kind of depends on there being a load of bioethics people around and available who've got, and this speaks to the last panel, who've got the training, right, and haven't just attended one master's, semester in bioethics, but actually have serious and sufficient expertise, not specialized in a specific area of neuroethics necessarily, or in a particular area of genetics or whatever, but actually have got skills across the piece. Rapid reaction, like I say, depends on the availability of people who you might not need to call on all the time. And so it requires from the funders, and this is where we're confident in doing it at Wellcome, that you may not always need the people you've trained up. You may not always need the research that you're doing. But when you do need it, it's absolutely worth having done the investment. But that's a really difficult question for a public funder who are accountable to politicians, who are accountable to taxpayers. We as a private foundation have a moral duty to do the things that our public colleagues cannot do because we're free to do them. But we don't have the scale and scope that NIH does. And I think there is an opportunity there. It wouldn't be a huge amount of money, but for NIH to make available funding that enables that capacity and enables that availability. But it requires confidence in saying, we think this is worth investing in because eventually something will come of it.
Thanks. That wasn't a plant, I promise. Okay, Eric.
So first, I just thanks, and then a suggestion coming back to the patient groups and rare conditions. So the thanks is that you guys are having this conversation. As someone who doesn't consider myself a bioethicist at all, it's amazing that you guys have created this space to have this type of conversation. And as maybe a bit of like outsider looking in, some things I'm hearing, it's something to think about building on, could be, first the term, right? Dan and Tanya, particularly building on what you guys are coming out, right? It's like, is it bioethics or perhaps is it health ethics? How might that just create something that is more inclusive, and similarly health research? But then a second layer with that, what if part of what you're thinking about is less about being the policeman, which I think comes to kind of a biomedical frame of mind where you're about diagnosing and treating, and instead you start taking not even a prevention, but a promotion frame of mind. Like what I'm hearing, this might sound totally crazy to you, but it sounds a lot to me like Steve Jobs and Apple. How? I think one of the things that Steve Jobs said very famously about Apple was that the secret of Apple is design, good human-centered design. And if anything, what was the solution of the past? It was around getting good human-centered design. I'm sort of wondering if health ethics is that next type of secret sauce that you could kind of advance work with the different types of layers that you were guys just talking through. But it's not about diagnosing and treating. It's about actually promoting and making something better. So that's the thanks, that you have a space to play with that. The comment is coming back to patients and groups and like the structural inequities. There's a common rule within internet, or not a rule, but like a pattern that's observed like with Wikipedia and other. There's sort of this 1% of the community contributes 95% of the content, and then 9% contributes the rest, and then 90% take advantage of the benefit. I think that's a really interesting model for us to be thinking about, right? Because I think classic science, we sort of go for, we do the 0.1% and we help the 99.9%. But perhaps our goal is not to try to build 100% of people engaging, but building a really strong, diverse group of 10% of the people for any key issue that we're talking about. And then making sure we build the economic models that support people in engaging in 9% practices. It's not going to be their day job, but we need to make sure we pay for them to be at the room. We build space for them. It's like Google's 20% time, right? Like you build that spot such that people have the flexibility so that they can be. Because if you don't do that, so there's a big economic layer to this. But just sort of the 1990 might be an interesting frame for us to be thinking about to build on Tanya's point. And again, thank you.
Anybody want to opine? Otherwise, we can let Alex talk. Okay, sure. Dan.
Thanks, great point. I would just say that the idea about health ethics or thinking more about prevention and promotion, I think we used to call that social medicine, right? There were departments of social medicine up and down the United States, and they kind of got shut down because you can't measure the outcomes.
There's a few of them still around.
Within 2 or 3 years, right? It takes...
UNC has a Department of Social Medicine. I think, doesn't Harvard also have one?
Yes, Harvard has social medicine.
Super. Okay, so there's 2 remaining. But the difficulty in not having like immediately measurable outcomes, and it's again, it's a thinking more long term and investing in this rather than assuming it's an input output kind of thing.
Alex.
Thank you. Alex Capron, USC. The title of the session is Looking to the Future, Anticipating Ethical Issues in, as Eric just said, health research broadly. And this morning we had a good deal of emphasis on the ways in which big data and algorithms relying on accessing so many sources of information, not just narrowly health information, are the wave of the technical future. And so the reason I have my laptop open is because I see a conundrum arising for us, which could use some thought, maybe from Shakespeare, but maybe from a variety of other fields, in that the definition of human subjects involves someone about whom private information is gathered. It can also involve someone with whom you directly intervene, but that's not at issue with this. And the definition now at 45 CFR 4611E4, just so you know where this is coming from, is information about behavior that occurs in a context in which an individual can reasonably expect that no observation or recording is taking place. And when we created that back in the day of the National Commission and so forth, the thought was that there is a liberality for researchers who are out in the world, seeing people, and the people realize that other people could be watching them, or who are using publicly available data sources that you could look up then, the phone book, court records, and so forth. And the sense was that people don't have a reasonable expectation that that information is private. But today, with all the attention to what the internet gives us and how it is possible to combine data to have this total picture of everyone's life, can we say that any information about our lives and our health is something about which we would have the reasonable expectation that it is private, that it is not known by others? And so we're sort of in one of those catch-22s that what made sense 50 years ago when we were defining this now has been overtaken by our friends in computer science, and we need to rethink what is it that we were concerned about and how do we come to a new conclusion about what we were trying to protect by having that definition of private information, and is there another way of describing the interest which isn't technologically overtaken? Thank you.
Like a research project in waiting, I think. David?
Yeah, I think that that's an incredibly important topic area for further research. So I don't have, I don't think there's an answer that a panel could give you in short order that would be satisfying. Yeah, no, I'm afraid not. But I do think that just to add sort of extra content to what you're on about is that it comes down to that question of what a reasonable expectation is in its narrowest legal definition, but also in terms of norms. And I think that the world has moved on sufficiently that whatever was intended in the original framing of that, it needs some serious rethinking. Now, both in terms of legal and ethical analysis, but also empirical analysis to understand how people interact with statements like that or how they conceive of themselves. This contextualization of data and how thresholds of their expectations go up and down is also really important to study as the technological landscape and the use landscape changes. I've been, for the last year or so, participating on an OECD expert group on digital skills for data-intensive sciences. And one of the things that has really come to my attention is the training need for all of the people who work in these data-intensive sciences and all of the support staff around them to actually start thinking through some of these, because they actually, as some of the people who are involved in the custody, collection, custody, analysis, storage of a lot of this kind of information, they really need to understand that they're actually implicated in those questions about the legal and normative safeguards. And I think it was observed earlier in the morning that I think we need to be attentive to this because it's changing quite rapidly, and that there's probably grounds for optimism that people are attending to this because we were looking just at the machine learning and AI context alone, and a quick survey of this revealed that there are over 800 initiatives in AI and machine learning and ethics ongoing in the world at this point in time now. So everybody's gone off in all sorts of different directions. But nevertheless, I think this is being well attended to. I do think, though, that when you go right back to thinking about a patient-oriented consent model, though, it's at least severely challenged, if not utterly broken. And I think that that's a research topic in its own right by the big data challenge. And I think that that's probably true in both research and in clinical contexts. So I think there's a lot of work to be done there. Yeah.
Sure. Dan, and then I'm going to ask Ben and Elaine to be brief, and I'm going to close us after this last round.
I think that was a fantastic question. So it turns out that moral norms change over time, right? And the notion of privacy we had in whenever it was that we did that, would have been totally alien to someone living in the 17th century, that idea of privacy. And I think it was Pilar was saying earlier this morning that there has been a generational shift, an extraordinarily rapid generational shift in what we consider to be privacy. We can get at what those experiences and expectations of privacy mean through some of the disciplines that make up bioethics. That's the role of anthropology, it's the role of sociology and STS. And we can fold that in to the next statement that we want to make about what we're trying, as you say, to protect. Yeah.
Okay, Ben.
Okay, I'll be brief, which means I'll be a bit more terse. I got two comments I want to make. One is I want to point out that the term bioethics is intended to be inclusive and distinguished from medical ethics. And I think the term was first coined by Van Potter, I think back in 1970, to include the biological sciences. And I think there's really a value to that inclusivity, so I'm not sure I'm not enthusiastic about abandoning that term. The second point really has to do with the issue that was raised and discussed about emergent issues. And what I want to point out, there's a few people in the room who are involved with our National Research Ethics Consultation Collaborative, which really grew out of NCATS. And I want to point this out as an example, something that the NIH really actually did that has been successful, even though it's not currently part of the CTSA program. But back in 2006, when there was a requirement for a ethics program as part of the CTSAs, what grew out of it and has been sustained often institutionally are these research ethics consult services that provide opportunities for investigators who don't have embedded ethicists with them to ask questions of them. And I think that we haven't talked about that, but I think that's an important dimension to this whole question. Thank you.
Helpful both. Great. Elaine.
So my question relates back to what David was talking about just now and also the discussion in the morning. And the question about not only the patient and the person delivering data, but the researchers who are actually using that data for their research. And it's good to hear that there's now discussions of ethical management of data, but I think the discussion about how one, as researchers on the receiving end, who are not seeing the person who gave it, what are their concerns and how do we deal with ethical issues related to that? I'm not talking about regulatory review, not regulatory issues, but ethical issues, and trying to think through what are the kinds of things that those people should be having up front as far as training about how you think through what projects to do, which data to use, which data to combine, et cetera. And
Well, just I think some of the things we talked about today, in fact, are things that we're seeing certainly in the OECD report. They'll show up there, but things like structural bias in data itself, being attentive to unintended consequences of algorithm development and use, potential for dual use of algorithms. Taking data from one domain and applying it in another domain where you can probably, I think, have a reasonable sense that that would be an affront to the original providers of the data, so on and so forth. Certainly, you know, this issue about the AI for policing and facial recognition is something which has, I think, become a cause célèbre in the AI and machine learning ethics community as being it's just exactly what you know, creating AI dragnets basically is sort of seen as a limit case of the use of that kind of data. And I think that increasingly where the limits will be too is that people might well think, say, if they're serving a private interest who has an interest in selling a product or service, that you know, looking at you know, likes on you know, Facebook or something like that is all very interesting. But I think that some of that behavioral modeling can also be used in ways to fundamentally change people's choice architectures. So it's a little bit like nudge plus plus. So there's quite a spectrum of issues that are now actually going into decisions that or curricula meant to actually help data scientists and people who work with them, data engineers and the like, to be better stewards and users of data.
Great. Thanks to the three of you. Thank you to the participants who raised questions during this part of the workshop.